It's a phase 2 single-arm study looking at locally advanced unresectable pancreatic cancer patients who typically would go through chemotherapy. And except right now, we don't really have a standard treatment. If you look at the older data, gemcitabine is usually the standard treatment, but we have a lot more newer regimens in the metastatic setting. But we have no real data right now to say, does they play any role in the locally advanced setting? So this is the first study where they're looking at metastatic treatment in the locally advanced to see if there's a conversion to changing unresectable to resectable and outcomes and safety. So with the TTF and the PFS that they found, which was just above 10 months for both, I found it was a little less than what I would have expected, what I normally see. We do see patients living longer, but again, it is an average number. So there are some people who live less, some who live more. The overall survival, 1 year overall survival was 72%, which again, I kind of feel is a little less, especially when you're talking about a clinical trial where you're picking the creme of the creme kind of patients. You would kind of expect for them to do better. So I kind of felt it was actually a little less than what I was expecting. So the partial response rate was 35 patients out of the total of the 106 who actually had a partial response, which actually was a lot less than what I expect. Now, there was over 40 patients that actually dropped out. So this is from the total population, 35 of which really have 65 that actually had a partial response. So it's a little lower than I would expect and what I usually see. We usually do see at least a partial response with treatment as well. So the data itself was really good, that it actually does show that chemotherapy can convert locally advanced unresectable to resectable. 16 patients were actually able to undergo an R0, R1 resection. So we actually have data now that says, yes, chemotherapy can convert. So it is actually quite meaningful because when you talk to patients, before we always said, there's a good chance that this will happen. Now we actually have physical data that we can present to them and say, yes, it does work. So with the induction chemotherapy, the plans were for a total of 6 cycles before moving into investigators' choice of treatment. The average number of cycles was 5, which is ballpark what we do see. We do find there's a fair amount of toxicity where you end up having to do dose reductions or changing the treatment plan a little bit in order to get them to 6 cycles. So 5 cycles actually seems actually even a little more than what we actually typically see with the patient population. But again, it's also a clinical trial, so therefore the patients that are being rolled into this study are the best, or the creme of the creme. The safety results were as we would expect for gemcitabine and Abraxane, myelosuppression, diarrhea. None of it was unexpected. It's what we see typically and what we manage as well. A lot of times the management are supportive slash using dose reductions further on to keep them on treatment as well. With patients, whenever they present, they nowadays have an idea about what chemotherapy is, and really quality of life is extremely important. They do not want to be in bed sick, which is what they depict when they talk about chemotherapy. So when they hear things that quality of life is able to maintain or might even improve on treatment, they become much more open to the concept of going through that kind of treatment regimen. In Canada, before, we never really had data to support this, but it is still being utilized as a regimen that can be used in a locally advanced setting. So with data now, we have a little more evidence that when we go to the patient, we can say, yes, this does work. And so it is something we would recommend to patients to undergo to see if we can convert them to something that can be resectable. So the data itself really probably is not going to change practice, because that's what we're doing right now. The problem is it's a single-arm study, so we're not comparing it to something else. So it's not like saying this regimen is better than another regimen, for example. It's being utilized already in the locally advanced setting, so it's not going to change it, but you feel a little more confident when you speak to patients that this will potentially help them to become more resectable, because there was a percentage of the population that did get resected on the trial. Right now, I mean, the biggest thing is to try to determine what regimen is best. And we don't know differences between FOLFIRINOX or gemcitabine and Abraxane, which one is better. And to have a study comparing the two, I think would provide the best information for us to try to determine tolerability, number of cycles, as well as which one actually gets you to a better conversion rate. And I would love to see that kind of trial.